Okay, yeah. All right. Well, morning, everyone. Sorry for the delay. For those of you who I haven't met yet, my name is Arran Seiler. I did my residency at the University of Utah, and then last year I was at University of Chicago for an OB fellowship. Just moved north of the Cheddar Curtain back in August, and so here I am. So when I was given this opportunity, I figured what better thing to talk about than obstetric anesthesia. A big part of my fellowship was working with other providers and assisting them in the care of pregnant patients during non-obstetric surgeries. Because one of there was a lot of myths out there for one reason or another. Something happens and a provider attributes it to medication X, Y, or Z, and then they say, well, we can't do this anymore because something happened. And despite a strength of evidence for that, it just kind of stays the way it is because no one really wants to question it or, ask pregnant women to volunteer for studies where we prospectively expose them to various things to see what's true or not. So that's kind of why I wanted to talk about myths of obstetric anesthesia. Next slide. Okay, so the first, is it on like the presenter mode, or do you just want to get like the main slides?
Sorry, I'm not sure.
Yeah, if you click on display settings, you should be able to change it.
Okay. It's just.
Yeah, so you can just go to slideshow at the top, and I'll just. And yeah, start from the beginning. So that's
I guess I'm not sure I understand.
Oh, because like it's in presenter mode.
Is that better?
Well, that.
No.
Oh yeah. Okay, there. Yeah, and then I'll just tell you to hit next.
Okay, great.
Okay, excellent. All right. So the first myth, you can hit next right now, is that lectures are engaging. You can hit next again, and that you're going to retain everything that I say. Unfortunately, that's not really true. Lectures are not a very productive way of relaying information from one person to another. Adult learners especially have an attention span of about 15 minutes. You can hit next again. Sorry, I wish my arrow would work so that I wouldn't have to keep telling you to do that. So my apologies. But anyway, adult learners were a little bit better than goldfish. This 15 minutes comes from a study actually looking at people in residency and fellowship programs. So I thought it was particularly applicable to us. And that comes for many reasons. It can be that people are at different stages of learning. Some people here are in the very beginning of their residency. Other people in the audience haven't done obstetric anesthesia for years and have no desire to go back to it. But more importantly is that working memory is a very energy consuming process. And so for those of us who are hearing things for the first time or maybe for the second time, it takes a lot of attention and effort to really learn new things. And you can't keep doing that for an hour straight. And so after about 15 minutes, your mind just can't process new things. And at the end of an hour, you retain about 5 to 10% of it. Next, please. So what I'm going to try to do is I've planned some intermittent breaks here every like 12 to 15 minutes or so. And we're just going to talk about something that is completely unrelated to obstetric anesthesia. We're just going to look at some pictures and give your mind a moment to kind of rest. It's a little unconventional, but just let me know what you think of it, and we'll move on from there. Next, please. All right, so the reason why I'm doing this next is there are over 80,000 non-obstetric surgeries in pregnant women every year in the US. And so this is applicable to everyone. Even if you have no desire to do obstetric anesthesia, you will get patients in the operating room for one reason or another who are pregnant. Next, please. Almost half of all of these surgeries are abdominal in nature, appies and choles. Young adult women get appendicitis and they get cholelithiasis, and young adult women also get pregnant, so they overlap. Next, please. And then a quarter of these are orthopedic surgeries because, again, young adult pregnant women get in car crashes, they slip on ice. Domestic violence is unfortunately a very real thing, even in pregnancy. And so you're going to be doing ORIFs and spines and everything else on pregnant women. Next, please. Okay, so my first case is a 27-year-old G2P1. She's at 24 weeks and 5 days, and she's got acute cholecystitis. Past medical histories are notable for obesity and asthma and anxiety. Her allergies are penicillin. I'm just using this penicillin thing as a platform to reiterate that the myth between penicillin and cefazolin is not true. This is not inherent to obstetric anesthesia, but I just figured since I had this moment, I would share that again, since this still comes up probably at least once a week on labor and delivery, as well as in the general ORs, that people think you can't do ANSEF. All right, next, please. So the first one, the big one, is midazolam. And people say, well, if you give someone Versed, then the baby's going to get a cleft lip or palate. And so where does that come from? Next, please. So there was a study done in 1975. It was a survey out of Atlanta. They published it in The Lancet. And basically what they did was they sent out a survey to mothers who had children with various congenital abnormalities and basically asked them, did you take any of these drugs? And so the problems with this are, one, it's a survey, which is notorious for having low participation rates. Because if you think about it, you know, whenever you come home from vacation, you get an email like, hey, please tell us what you thought about this trip. You're never going to fill it out unless you have something to say. And so by doing these surveys, you're really fishing. And their audience is mothers who have babies with congenital malformations. And so it's kind of like those commercials you see where they say, hey, did you take Zantac? Did something terrible happen in your life afterwards? You might be entitled to compensation. It's the same kind of idea there. And so they're very biased. Additionally, these were not, the medication list was not an all-inclusive list. There was a list of meds on there, but you know, it certainly didn't have everything. Their control group was not healthy babies, but babies born with Down syndrome, which I thought was a very interesting control group to have. I'm not really sure why they did that. This was done in the 70s, so there were no electronic medical records to verify this stuff, and there were no pharmacy databases that we could ensure that the patients were actually taking the medications that they thought they were taking a year prior or more. And so it has a lot of limitations to it. And the authors recognize that, and they kind of try to temper their argument, and I'll show you that later. But despite that, this myth has persisted for decades. Next, please. So the first is that the lip forms between the 4th and 7th week in gestation, next, and the palate between week 6 and 9. So anything that you do after week 9, there's no mechanism for midazolam or any other benzodiazepine to circulate through mom, cross the placenta, go into baby, and break open an already formed lip or palate. Like that just does not happen. Also, midazolam didn't come out until 7 years after this study came. And so to really try to link midazolam to this study is not really accurate. Next. And then more recent studies out of Israel and Europe have not been able to support this claim of benzodiazepine exposure and cleft lips and palates. Next. And next again. So here the authors put a couple of times how this is just an association and it could just be due to chance. They write further on that it was only found for cleft lips and palates and not other abnormalities. Could just be due to chance. They also mentioned how one person mentioned exposure to other medications such as diphenylhydantoin, which is known to increase the incidence of oral clefts. Next. Yeah, okay. And then they also talk about how there is no secular trend in increasing rates of cleft lips, and I'll get to that in a second. But they also mentioned that 2 previous studies looking at chlordiazepoxide, which did not show a link between benzodiazepine exposure and cleft lips and palates. And when they looked at their own data, they also did not find this link with chlordiazepoxide. And for those of you who are fans of the show The Queen's Gambit, Librium, this drug, is the one that the main character was addicted to. And then this graph here, or this table, what it's showing is that over the years from 1968 to 1974, the number of diazepam prescriptions more than tripled. However, the rate of cleft lip and palate in the city of Atlanta stayed the same. And so what the authors are saying is that despite this dramatically increased rate of diazepam exposure, there was not a equal rate in the change of cleft lips and palates. So they are really trying to show that, they found an association, but they don't have a mechanism for it. It's not found in similar drugs. The prescriptions to incidence doesn't match up, and so they don't really know what's causing this. They also don't claim that that benzodiazepine exposure is causing this. However, it has persisted quite a lot, and I've seen it in Utah. I've seen it in Chicago. I've heard about it at Vanderbilt. I've seen it here. So this is a very widespread belief. All right, next, please. Oh, okay, great. This takes us to our first break. So this is the city of Pittsburgh. I was actually born there. You can't see the hospital in this picture. But anyway, the river to the left side, which is north, is the Allegheny. The river to the right, which is south, is the Monongahela. And they come together at that point there and form the beginning of the Ohio River. And what you see here, you see a lot of bridges. Pittsburgh, it takes a lot of pride in their bridges. They claim to have the most bridges in the world at a little over 400. On the left, you see there's that first yellow bridge with the rounded top. But further upstream, there are 3 identical yellow bridges. Supposedly, that is the only place in the world where there are 3 identical bridges. Those are the 6th, 7th, and 9th Street bridges in Pittsburgh. Next, please. This bridge is the Smithfield Street Bridge. This is actually the 3rd iteration of the bridge over its history, but those stone pillars, or whatever you would call them, are from the preceding one, which was the first steel wire suspension bridge in the world. It was designed by John Roebling, who is also known for designing the Brooklyn Bridge. That one, I guess, is a little bit more famous than the Smithfield Street Bridge, but still a notable point in Pittsburgh's pride. However, their claim to having the most bridges in the world is a little bit inaccurate. Next, please. But given that the best thing that Pittsburgh has going for it culturally is that they put their French fries on their sandwiches, I figured it's probably best to just let them have this belief, because otherwise they're just clinging to the 1979 World Series. Next, please. So this city has 3 times the number of bridges as Pittsburgh, with 1,200. If any of you recognize it or don't recognize it, the bicycles might be a little clue. This is Amsterdam, with, like I said, 1,200 bridges. However, Amsterdam still has to take the silver medal. Next, please. Because this neighboring city, next, has more than double Amsterdam. So the gold medal winner, one more, is Hamburg, Germany, with 2,400 bridges. Fun thing about Hamburg, I used to live there, and I've learned that most places you go in the country, if you tell someone that you lived abroad for 2 years in your early 20s, they assume that this was like a exchange student thing, or you're teaching English or some education-related event. However, if you're in Utah or Southern Idaho and you tell people that in your early 20s you spent 2 years abroad, they come up with very different assumptions as to what you were doing. So that was something I learned in Utah. A little shout out to the Provo crowd there in the audience. Next, please. Okay, so back into the meat of the talk. So rapid sequence inductions. So the belief is that pregnant women are high aspiration risks. Next. This comes from Dr. Mendelsohn. He named a syndrome after himself, very, very modest behavior back in the 1940s. And he was working in New York City, and he was looking at deliveries at his hospital from 1932 or 33 to 1945. They had 44,000 deliveries and 66 cases of aspiration pneumonitis with severe adverse events. Now, deliveries back then were very different than they are today. So first off, we didn't have epidurals. The thought process at the time was this is a really big event. It takes a lot of strength and energy. And so you should have a big hearty meal to get the calories you need to have a baby. And then when you're having a baby, we're going to dope you up on barbiturates and volatile anesthetics like ether or cyclopropane or halothane. And basically, we're just going to put you into a state of general anesthesia without an airway, with a full stomach, 4 hours while you are delivering a baby. Turns out about 0.15% of the time, something really, really bad happens, which if you think about it, is not a surprise at all. So what is true is that progesterone decreases lower esophageal sphincter tone. Next, please. And the gravid uterus increases your intra-abdominal pressure. And so what happens is the margin of safety between your intra-abdominal pressure and your esophageal pressure becomes narrower. And so if you think about it, how is this different than GERD? And the answer is it's not. It's just GERD. Pregnant women, they get GERD. And so your technique for managing the airway in pregnant women should not be dictated by the fact that they're pregnant. It should be dictated by however you treat patients with GERD. And so if your practice is that you will always RSI and you will never use an LMA in a patient with GERD, like by all means, that is totally fine. It's not an unsafe thing, and you're not wrong to do that. I'm just trying to highlight here that if your rationale for it is that they're pregnant, that's a little bit inaccurate. Okay, so what about gastric emptying? Because people say, well, gastric emptying is different in pregnancy. Next, please. So fasting gastric volumes are not different between pregnant women and non-pregnant women. They've looked at this with ultrasound and found that the volumes and the volume per size of the patient are equal. So as long as you are adhering to your NPO guidelines, you're good. What happens is when you're in labor, then your gastric motility is shot. They're basically like a trauma patient in those regards. Also, laboring women get opiates because before they get an epidural, or back in the days when people thought that epidurals were dangerous, the treatment for labor pains was just tons and tons of IV and IM Dilaudid and meperidine, and of course those will certainly decrease gastric motility. And for the LMAs, there are 2 case series with 3,700 people. These come out of Europe. They did all these cesarean deliveries, so big abdominal surgeries under an LMA, general anesthesia, and they didn't have a single aspiration event. And that's because they all adhere to their NPO guidelines. Next, please. Okay, neuromuscular blockade. So this one kind of exists in the ether. People have probably seen this in a test question, or they've heard someone mention it. This whole idea of atropine, like should I use atropine for neuromuscular blockade reversal instead of glycopyrrolate? And so this comes from a case report in the mid 90s. What happened was there was a young woman with schizophrenia. She needed an ORIF of her humerus, and during the case, they were doing intraop fetal monitoring, which is its own very controversial topic. If anyone has questions about it, I'm more than happy to talk to you about it later. But at the end of the case, they gave her 5 milligrams of neostigmine and an accompanying dose of glycopyrrolate. And the baby had transient fetal bradycardia to the 90s to low hundreds, which is certainly bradycardia. Anything under 110 is by definition fetal bradycardia. But that is the kind of bradycardia that makes you maybe look closely at the monitor. Maybe you're going to get out of your seat, but you're not going to run and set up an OR and start splashing a belly for fetal heart rate of 100. It went away with left uterine displacement. 2 very common causes of fetal bradycardia are maternal hypotension and maternal hypoxemia, both of which are treated with left uterine displacement. However, the authors decided that they were going to attribute this to the neostigmine crossing the placenta, the glycopyrrolate not crossing the placenta, and the baby got an unopposed parasympathetic response from the neostigmine. So 5 days later, she needed to come back to the operating room because her wound it either got infected or she re-injured it. And this time they decided, well, we're going to use atropine because atropine will cross the placenta and we're not going to have this problem. And they did it, and it turned out to work just fine. So that was their proof that proved their point. Okay, so whenever someone brings this up to me, I always ask, what dose do you use? And the reason why I do this is because no one knows the dose. No one uses atropine for neuromuscular blockade reversal. They actually did use 0.4 milligrams IV in case anyone like really wanted to keep that in the back of their mind. But what I try to illustrate here is what is more dangerous: to use a drug that we know how to use, we know how to dose it, we're very familiar with it, we use it all the time, and then there was this one case report that said that there was fetal bradycardia, and it might not even have been due to the neostigmine per se, but we kind of just attribute it to that. Or do we use a drug that we only ever use in a code or peri-arrest type of situation that no one really knows how to dose and crosses the blood-brain barrier and potentially exposes mom to central effects of it? So my argument would be to not use atropine. So what about Sugammadex? Absolutely. You can use Sugammadex. It's what I would do in this situation, not because I'm concerned about the potential fetal bradycardia, but because it just is the superior neuromuscular blockade reversal agent. The stronger study has shown lower pulmonary complications. They've looked at it in thoracic surgery patients, end-stage renal disease. Next, please. And there's even a case series out of Michigan looking at pregnant women who have had Sugammadex exposure and no complications from it. The idea is that the Sugammadex can bind the progesterone and cause problems with miscarriages. That comes from the package insert in the Sugammadex containers. That is what someone just wrote. It's unpublished data, so feel free to use unpublished data however you would like to use it. But when they look at this in animals and they give them whopping doses of 32 milligrams per kilo, there was no increased miscarriage rate. The small case series out of Michigan showed no problems. And so you could say, well, Arran, that's an animal study and that's a small case series, and you can't really draw conclusions from that. And I would say you're right. That is a significant paucity of evidence, but there is no evidence of harm. And so I would go with Sugammadex in this case. Next, please. Oh, all right. Another break time. So this is Mount Timpanogos, another shout out to the Provo crowd. This is my favorite hike to do. That peak is 11,700 feet. Next, please. One of my favorite reasons for it is because these guys are there. I've done the hike about 7 times and I've seen these guys like 5 or 6. They are super cool. I think they're docile. I don't know. Sometimes they kick stones down. So you got to watch out for that. But I just try to avoid them because they got spiky horns on them. But otherwise, where else do you see mountain goats? Next, please. If you go out to Western Utah, these are the Bonneville Salt Flats, famous for their land speed trials. It's especially cool when you go in the early spring, like right after a rain, which does not happen out there because it is super flat. And you get this like inch of water everywhere. And if you can get out there when it's not windy, it's like a giant mirror. Also, I've licked the salt flats. I wouldn't recommend it. It is very, very salty. Next. Also out in Western Utah is Sun Tunnels. This is an art installation. There are actually these 4 tunnels and they're lined up so that on the winter and summer solstices, the sun rises and sets directly through the tunnels. Also, there are holes drilled in the roof of it, and so they'll form the constellations that you see that time of year inside. Next. Down farther south, this is Capitol Reef National Park. Next again. This is they call it the Grand Canyon of Utah. I forget exactly what it is. I've seen Dexter participating in the chat. He probably can remember what it is, but I think that's part of the Green River. One more. Arches, where we get our license plate from. Next. That's Bryce National Park. This one's probably my favorite of Utah's parks. One more. Zion, they consider, I guess, the gem of the 5 national parks in Utah. It's, I would say, maybe number 4 for me. It's just very crowded, but it is gorgeous. Also, St. George, Utah is super, super, super hot in the summer. So if you are going, I'd recommend like January or February. Next. Now we're in Eastern Utah. This is Amethyst Lake. It's around 10,000 feet up in the Uinta Mountains. One more. Okay, this is what I really love to do out in the Utah wild. This is in Little Cottonwood Canyon. This was actually a pretty bad day. I almost got stuck out there. And that would have prematurely ended my my residency, but I couldn't get out. One more. Lots of moose up there. Try to avoid them.
Spot in sorry.
One more. Okay. And this is Little Cottonwood Canyon again. So this is ideally when you go snowshoeing, you try to get this. You try not to get caught in a snowstorm. All right, and I think we can go back into the. Okay, so final stretch. I hope that break was able to get everyone's minds back ready for more learning. So second case is a 19-year-old. She had a tib fib fracture from an unrestrained motor vehicle crash. Here, her allergies are listed egg and soy. Again, this is not unique to obstetric anesthesia, but there is this myth out there that propofol allergies react with egg and soy. There's a study out of Denmark that kind of refutes that. But I just figured I would use this platform as an opportunity to highlight that. All right, next. Okay, so there's this belief that regional is safer and that we should do this case under a nerve block. That's not wrong. The idea being that by doing this with a regional technique, we expose mom to less anesthetic, that exposes baby to less anesthetic, and is therefore safer. Next, please. So no current anesthetics that we use at clinical doses have been shown to ever be teratogenic to the baby. Next, please. And so no anesthetic technique is really superior. And that kind of depends on how you look at it. So, if you're looking at maternal mortality or something like that, that's a very, very rare event. And so you're never going to have anything powered strong enough to show a benefit there. But really, unless you are delivering the baby immediately afterwards, it kind of doesn't matter if you use general anesthesia or not, because the baby's going to metabolize, mom is going to excrete it, and it's not really going to be relevant. It's only more of a thing for like cesarean deliveries, where we try to do them under neuraxial because we really don't want baby being born under general anesthesia. So the case and the comorbidities of the patient, aside from the pregnancy, should be what you use to determine your anesthetic plan. And so if this is a fracture that can be repaired within like 90 minutes, then by all means do it under a regional technique. It prevents you from needing to manipulate the airway. It was a great anesthetic plan, but it's not necessarily safer. If the case is more complex and it's going to be like many hours, it's kind of a lot to expect a patient to just lay there totally still, listening to hammers and drills and buzz saws and everything during surgery. And then if you're going to sedate the patient, well, then you're just exposing them to anesthetics anyway. So if it's a really long case, you might as well just do it with a secure airway. Also, depending upon the other comorbidities or the other medical considerations at the time, the hemodynamics of a neuraxial block may not be better for the patient. And also, I wouldn't do anything as far as like telling a general surgeon, if we're going back to our lap chole, I wouldn't tell a general surgeon that they need to do this with an open technique so that we can do it with an epidural and spare the patient exposure to general anesthesia, because an open chole is a much more morbid procedure than a laparoscopic case. And so to say that one is safer than the other is not necessarily true from a pregnancy standpoint. Again, for airway considerations or for like chronic pain issues, et cetera, then you can make an argument that way. Next. Okay, no radiologic imaging. You should avoid radiation during pregnancy. That's also not true. Radiation, as far as like imaging studies go, is safe. The big exception is no radioactive iodine during pregnancy. What happens is that it will cross the placenta, and then the radioactive iodine will be taken up by the baby's thyroid. Just living life in pregnancy, you get around 1 to 6 milligray of radiation. A flight from O'Hare to Rome will get you about 0.05 milligray, just to kind of put it in perspective, which is a lot more than a chest X-ray. And I'll show you a table in a little bit. So this, again, we don't have amazing evidence behind this because we don't randomize people to radiation and not radiation. But the best evidence that we have is that as long as you keep your cumulative dose under 50 milligray, you're not really going to have any big congenital abnormality. Like you're not going to have limb defects or CNS defects or intrauterine demise or anything like that. One more. Leukemia is a trickier subject. There are some studies that show a link. There are other studies that don't show a link. The ones that do show a link, your relative risk is on the scale of like 1.4 to 1.5. So it's really not that big of an increase. And again, since we're not, doing prospective studies here, we can't really tell, is this because of the radiation exposure, or is this just because there's something about the mother, her disease process, that whatever it is that requires a radiation exposure, the link isn't very strong. But if you look at this table, you can see a couple of the common things up here. So I mentioned a flight to Europe is about 0.05 milligray. If you look at a chest X-ray, that's less than 0.01. Skull, T-spine, they're all very low. Any of the X-rays are incredibly low. Even when you get to the CTs, if you're away from the belly, so if you're doing a CT chest or CT head, there is extremely low radiation exposure. The biggest one is going to be your CT pelvis, which makes sense. It's a CT, and you're right where the uterus is. Even the average exposure from a CT pelvis is half of what we believe to be the safe upper limit. And so if you ever find a proceduralist who is kind of on the fence about whether or not they should get an imaging study, or if they want to change their treatment plan because they're concerned about the radiation exposure, you can be an advocate for the patient and just tell them to do what they need to do to provide the best treatment. If you have an obstructing stone and the urologist said, well, normally we would put a stent in under fluoro, but I don't want to do that right now. So let's just try to treat this with antibiotics. If what they're doing is not the most appropriate form of care, then it's not what's best for the patient. The ultimate thing for obstetric anesthesia or obstetric care in general is just do what's best for mom, because mom is taking care of the baby. Dr. Schmidt asked about shielding during this study. I'd have to go back and look at it again, but either they did this with shielding, and so your skull X-ray and your chest X-ray, you have lead on the patient and it's super low, or they didn't use shielding and it just highlights that it's super low even without it. But yeah, whenever you're getting images of the extremities or the head or neck, then shield the mom or the uterus. Anything that is remote from the pelvis or abdomen is not going to be a problem for the baby. And going back to the urology thing, if they need to put in a stent, then they need to put in a stent, and because we don't want mom getting urosepsis, because that's certainly not going to be good for the baby. And then even something more high exposure, like a CT pelvis. If you get this patient who is in a motor vehicle crash and she has a complex pelvic fracture, and the orthopedic surgeons are like, well, let's try to do this without imaging, like that sounds like a really not well thought out idea, because what's going to be worse for the mom? A radiation exposure that is under the safe upper limit, or to have people mucking around with an unstable pelvis fracture without a clear plan as to what to do, because there's a lot of important real estate down there. And as bad as radiation is, maternal hypotension and underperfusion of the uterus is also very, very bad for the baby. So again, aside from radioactive iodine, everything else from an imaging standpoint is safe. There is some lack of clarity on gadolinium for MRI studies. There's some animal evidence that shows that it may be teratogenic. There's nothing in humans, but the argument is, or the guidance is, if you don't need the gadolinium in your MRI to really come up with your plan, then don't do it. Next, please. Okay, so now I'm kind of stepping away from non-obstetric surgeries to C-sections, just because there are many people who cover OB on nights and weekends, and many of the residents are going to want to go out in the world and do obstetric care. And so the idea is that don't use fentanyl or other opiates when you're inducing general anesthesia for a C-section. And so the thing is, when do we do cesareans under general anesthesia? In the U.S., an arbitrary marker of quality or excellence is to have a general anesthesia rate less than 5% for your cesareans. So the only times we do these are when there's an emergency, like a prolapsed umbilical cord, a uterine rupture, placental abruption, something really bad is happening. Next, please. And then another thing I want to highlight here is the difference between statistical and clinical significance. So this table, I cropped it out of a meta-analysis. I got rid of the parts about remifentanil and alfentanil. Spoiler alert, there is no difference in APGAR scores in patients exposed or not exposed to remi or alfentanil. And this is just fentanyl here. So if you look, we have 4 studies. The first 2 and the last one show no statistical significance if you're exposed to opiates or not exposed. The only one that did show a statistical significant difference was the 3rd study. And their APGAR scores were 9.4 in the patients who got 100 micrograms of fentanyl and 9.7 in the patients who didn't get any opioid. And so, fine. Statistically, that is, those are different numbers. But clinically, those are the same babies. Anything over 9 is amazing. Anything over 7 is a good APGAR score. And if you think about it, in the US, like, since we don't do general anesthesia cesareans, any baby that is born from a mom who's under general anesthesia, NICU is going to be there. So it's not like you giving fentanyl on induction is going to dramatically change the immediate plan for the baby. NICU is going to be there. They're going to do their whole resuscitation analysis, and the baby's probably going to end up in the NICU for a little bit. So you're not really changing anything in terms of the baby's trajectory by doing this. Also, preeclampsia is increasing in prevalence in the United States. The number 1 killer in preeclampsia is hemorrhagic stroke, and the biggest determinant of that, or I guess risk factor for that, is time with a systolic above 160. And so whenever I need to put an endotracheal tube down a pregnant woman's airway, I'm going to want to try to blunt her sympathetic response, because it does me no good to avoid a floppy baby if mom has a brain bleed. Okay. So that's my argument for using fentanyl if you need to on induction. Next, please. Okay, so in conclusion, a single dose of Versed is safe. You're not going to cause any congenital abnormalities by doing that. If the mom needs it because she's very anxious, just go ahead and do it. Next. Gastric emptying is unchanged in pregnancy. Next. Bradycardia with neostigmine, that came from a single case report. Do with that whatever you want. Your anesthetic plan should be determined by the comorbidities of the patient and the type of surgery that needs to happen, not by whether or not mom is pregnant. Radiologic studies are not contraindicated. Just do whatever you need to do to come up with a good treatment plan, and your APGAR scores are minimally changed with induction opioids. All right, next. All right, thank you.
Hi, Arran. This is Stacy Fairbanks. Great talk.
Thank you.
I guess since we have a couple of minutes, will you talk a little bit about the pregnant woman who has a viable fetus and whether you should have OB
Do intra-op monitoring
in the OR and do continuous monitoring? Yeah.
Yeah. Okay. So the idea here is, so any pregnant woman that goes to the operating room should get fetal heart tones checked before and after surgery. And basically what that there is to show that you have a live fetus going into surgery, you have a live fetus coming out of surgery. Nothing, we didn't do anything. And then if the patient is, or if the fetus is viable, then you also do like tochometry just to make sure that there's not uterine irritation. It's not really the same as preterm labor, but you can get some uterine irritation. So they just want to monitor for that. So the question becomes, if the baby is viable, do you monitor fetal heart tones intraoperatively to see what, like, if you need to do an emergency delivery? So the questions are, or the criteria that needs to be met. First, you have to talk to mom about this and get their consent, because it's one thing to agree to a lap chole. It's another thing to agree to waking up and finding out that you've just had a cesarean delivery and you now have like a 26-week fetus or a 26-week baby in the NICU. Like, those are very, very different things. So you need to get mom on board with that. 2, you need to have an obstetrician that's readily available who's like, oh, okay, yeah, this is a good idea and I'm okay doing this. You need to have NICU available, because if you're going to bring a 26-week baby into the world, like, you're not doing them any favors if you don't have NICU there. You need to have a surgery that you can interrupt. So if you're doing an L-spine fusion, like, you're not going to flip mom over onto her back, do a C-section, and then flip her back to finish up your spine. And then the other part to it is that the fetal heart monitoring is just like any other monitor. Sometimes it works, sometimes it doesn't work. And there are times when we look at our pulse ox and it gives us some crazy number like 78, and we just dismiss it because we're like, no, we know it's fine. Everything is good. I'm going to ignore this oxygen saturation of 78%. But what do you do when all of a sudden the fetal heart rate just goes down? Do you just say, oh, well, I believe it, I don't believe it? Also, it's not on you to believe it. You have to convince the obstetrician that it's not real, which is a very different thing. And so how do you determine when it's an accurate reading, when it's just some artifact? There's not a good answer for that. And then the other thing is, no one really knows exactly what a normal fetal heart rate tracing is under general anesthesia. Opiates and anesthetics, they will cause a decreased variability in fetal heart rate. And a change in variability is a very, very scary thing for obstetricians. They look at that and they freak out, because it's either something totally benign, like the baby is sleeping, or it's something catastrophic and requires emergent delivery. And so, the best evidence that we have is that our anesthetics will cause these changes, but we don't know to what degree. And then also, you're going to have an obstetrician who maybe isn't aware of that because they don't know anesthesia. And so you got to convince this person to not do an intraoperative cesarean delivery. So I'm not for it. We are supposed to offer it. And so, the way I do it is, I mention it, but I mention it in a way that it is not what I would necessarily recommend. And usually the obstetricians are in agreement, and they kind of talk to the patient and be like, hey, we're just going to check fetal heart tones before, check them after. But if you really wanted to, like, say we're doing a tib fib repair on someone who is like 36 weeks, like, that is a case that you could interrupt. We're remote from the abdomen. The baby will do generally well. But yeah, it's a muddy topic. And then I noticed there was also a question about nursing after general anesthesia. So big picture, for any Medicaid, or at least for any like anesthetic medication or pain meds, is that to just continue breastfeeding as is. Anything that we give mom, a very small fraction of it gets into the breast milk, and then the few metabolites that are there are really not orally bioavailable. And so by the baby consuming 1% of the metabolites, whatever we gave mom, and then not absorbing it in their GI tract, it really causes no harm. And the idea is that the benefit of maternal breast milk far outweighs any theoretical harm. There is a graph somewhere out there in the internet that basically shows all the medications. They're all green, which means safe, except for ketamine. Ketamine is the one that's yellow, and it's not because it's not safe. It's because no one has ever really looked at it. So there's no data, which I guess makes it like a class C drug or something like that. Anything else I can tell anyone?
Dr. Seiler, do you know if in the pediatric world, when we talk about sedatives, some of the more recent conversations surround more the child's development when they receive medications like midazolam.
Mm-hmm.
Do you know if there's been a lot of studies or any studies looking at pregnant moms who get different sedatives and whether there is long-term developmental outcome like information for those babies?
So in terms of like, when you say long-term sedatives, are you talking about like people who are on like daily benzos for anxiety or other like mental health things? Or are you talking more like anesthetics?
Yeah, so my background in the critical care world, one of the things that we have started to avoid as much as we can is using benzodiazepines for like sedation, right? Because the data for neurodevelopmental outcomes for babies who receive, things like midazolam as a drip don't bode the best. So, we sort of opt for things like Precedex and things like that. So do you know if anything has been looked at from the OB world where they've had mom exposed to XYZ and then looking at baby like a couple of years down the line and seeing if there's any changes?
There are, so the big problem is that, none of this stuff is randomized and prospective, which really limits what we can draw from it. There are, the best evidence that I've seen is that there's no real definitive, difference, and that the other thing is that you can't really determine like, is this the medication or is this the disease state that that put mom needs surgery because she has intra-abdominal inflammation from like a perfed viscus or something like that. And so we can't really tease out what is from the versed or what is from the intra-abdominal pathology, et cetera. Now, that being said, there is definitely a black box warning for any GABA agonist or NMDA antagonist in pregnancy or within the first 3 years of life, because the idea that that's when all the synapses in the brain form. And so, all is it's a great plan to not expose someone to these types of medications. But really what it comes down to is the risk benefit analysis of exposing them to an anesthetic or not treating their pathology that is going to require an anesthetic. And so sometimes you're just kind of, the way I look at it is sometimes you're just in a position of you have to pick two less than palatable paths, and you pick the one that is the safer of the two. Sorry, that's not a very good definitive answer of like yes or no. So.
Thanks.
All right. Well, I always enjoy getting on my soapbox about obstetric anesthesia. So if any of you have, want to find me in the hallway, pick my brain, I'm always happy to talk.
Thank you so much. And thank you so much for your patience with WebEx this morning. I really appreciate it.
Oh yeah, no problem. I would just blame myself for that. Since I don't know how computers work, you could just tell me it was all my fault. I would believe you 100%.
Well, it's not. I hope you have a great day and thank you again.
All right. Thank you. It was a pleasure.